and we're going to talk about acromegaly first. And acromegaly is an endocrine disorder. Now, most endocrine disorders, you have one that there's too much hormone and one that there's too little hormone. I'm only going to talk about acromegaly, which results from too much growth hormone in adults. So this occurs um, after they're done growing. Okay, so that's an important distinction because in children we call this something different. You'll learn that in pediatrics. Okay, so some of the facial features you're going to see on somebody is they're going to have what's called prognathism, and that means like their lower jaw is big, but it sticks out in front of, like, see this uneven jaw here. They have that. That's a telltale sign. The other thing, they have like this brow bone, almost like a caveman, is what it reminds me of, that you might see in the movies. And all their facial features are kind of get broad, and they thicken, so they look like harsh almost. And if you look in your textbooks, there are some good pictures there. Now, you can remember the ABCs. They do suffer conditions due to the increase in growth hormone, like they get arthritis. And you can imagine, I talked about this I actually taught this lecture, I think, for you guys in Med-Surg 1 when Miss Anthony was out. But if you have too much weight, it puts stress on your bones, and they can develop arthritis from this. Their blood pressure is going to be high. They can develop carpal tunnel syndrome, diabetes. So they can develop diabetes due to the increase in growth hormone. They have enlarged organs, which is not good. And field deficit speaks to, they can have like double vision and visual problems. So that is a safety risk. Not really too much to talk about on acromegaly. It's just too much growth hormone in the body, and then it just produces these, features in patients. Now, I told you last exam that we're going to do SIADH and DI this time. Now, SIADH, this stands for Syndrome of Inappropriate ADH Secretion. Okay, so patients become soaked inside. What that means is um, the antidiuretic hormone. I always have to turn that around in my head because it's antidiuretic hormone, meaning they're not going to diurese. So a lot of things can cause this. We talked about it in the neuro lecture with brain damage and TBI. It can happen due to drugs. It can happen due to lung cancer. Lots of different ways it can happen. But what's important is, like, how to identify it, what the signs and symptoms are. So if somebody has SIADH, that means they're holding on to more water, okay? And that means the sodium in the body, or I should say in the vascular space, is diluted, okay? So they're going to have hyponatremia, and that's why we see these symptoms in patients, because they're going to be prone to seizures. There's specific gravity in their urine because their body's holding on to the water, so the urine is going to be concentrated. So that means their specific gravity is going to be high. Okay, and that kind of throws students off a little bit because we usually say when you're dehydrated, you're high. But with SIADH, it's kind of a different mechanism going on. All right, people with SIADH are going to be irritable, and that's due to low sodium. They're going to have increased weight. It's interesting, they really don't get thirst because they're holding on to all that water. Anorexia is also a symptom of hyponatremia. Oh, look, I have salt loss right here. And then they could have decreased LOC, disorientation. Again, all these things are due to low sodium. Okay, so H2O is added to the body. That's the way Mike from Simple Nursing talks about it. And I told you the high specific gravity and head is not right. Now, a lot of these are duplications, so you could trim this down to study if you need to, and just, remember the signs of hyponatremia. So again, these are signs of hyponatremia. The orthostatic hypotension may put your patient at risk for falls. And then to treat SIADH, they're going to be put on a fluid restriction to stop them from drinking like free water, we call it. And they'll, monitor serum sodium levels. You can liberalize salt in the diet. The patients usually enjoy this, like they can eat chips and drink Gatorade, and they really enjoy that. Put them on strict I&Os. Make sure you're assessing, and especially the neuro symptoms, because when the sodium gets like 120 to 115, you really start worrying about seizures. And we talked about seizures and what to do in the last unit. The drugs to treat it include the Vaptin, so tolvaptan. Dimethylcycline is actually tetracycline, but it works to treat SIADH. And you may see hypertonic saline, but it's not given that often. Okay, so that's just a really concentrated saline solution. Now we're going to contrast SIADH with diabetes insipidus, because with diabetes insipidus, the ADH is turned off, okay, for whatever reason. Same, the brain injuries we talked about last time, or pituitary tumors. Those could be reasons for diabetes insipidus. All right. So their urine is going to be very dilute. They have copious amounts of urine. You can't even keep up with it. I've never seen anything like it. And it's like really like almost like water. It's like see-through. It's so light. Okay. So you don't need to know the difference between central and nephrogenic diabetes insipidus. But you just need to know that they're going to be diuresing. And because they're diuresing, they're going to have polydipsia because they are extremely thirsty. Whereas in SIADH, they are not thirsty. Okay, dilute urine with a low specific gravity. So that specific gravity, I'm down here, is 1005, so 1.005. And they're dry inside, which means they're going to have a hypernatremia. So the opposite of SIADH. Drinking a lot, dry mucous membranes because they get very thirsty because they're losing all their water, and decreased BP, so they could have safety issues. They could be orthostatic, okay? Now, the drug for this is called desmopressin, all right? And so you need to measure weight daily and encourage fluids. Also measure the specific gravity to see if it's going to go back to normal. So when you administer desmopressin, those are the kind of things you're looking at. You're looking for a specific gravity that goes up, okay? And also desmopressin can cause vascular spasms or vascular clamping down, right? So you have to assess your patient for chest pain, because people that have had an MI, this might not be a good choice for them. But that's something you're going to have to watch out for. It's common with pituitary tumors. I talked about that earlier. Never restrict fluids, and don't give caffeine, because caffeine is a diuretic. Remember, caffeine is like in a lot of different drinks, right? Coca-Cola, a lot of things I like to drink, but they need to avoid caffeine. And when you're evaluating desmopressin, that means, like, if you're asked to evaluate a medication, that means you're looking for symptoms that the patient is getting better, okay? So don't pick the absence of side effects when you get asked to evaluate a medication. They want, the question is asking you, how does this medication work? So what you will see if desmopressin does work, right, the urinary output is going to decrease. You're not going to have that copious amount of urine anymore. The specific gravity is going to go up. The sodium will now be in the normal level, and they'll have decreased thirst. BP is going to return to normal, and heart rate is going to return to normal. So anytime somebody is diuresing, right, they're going to have fluid volume deficit. They're going to have tachycardia. So their heart is going to go back to normal. And then I talked about this when we talked about brain tumors. If somebody has a pituitary tumor, this may cause DI, may cause other things too, like blindness and personality changes. The treatment is going to be a hypophysectomy, and a hypophysectomy is done either through the nose or up in the gums. Okay, and I like taking care of these patients when I worked in the PACU. It was, they were like critical when they first came out, and you had to watch their urine really closely. But the post-op care is all those things you learned about preventing increased intracranial pressure. So you want to keep the head of the bed 30. The patient should not blow their nose. They need to mouth breathe. And you test any clear drainage for halo or glucose. And no bending at the waist, no coughing, no flexing, no brushing their teeth, because that can increase intracranial pressure. And you have to warn them beforehand that they're going to need to breathe through the mouth. They have like a mustache dressing on if the provider went through the nose. So you have to warn them about that. Okay, thyroid. Now we're going to switch gears and talk about thyroid conditions. Now, with thyroid conditions, the first thing I'm going to talk about is a goiter. And this person right here has a goiter on their neck. That's where it shows up. Now, this can result in euthyroid, which means good thyroid, which means they could just have a goiter and nothing's wrong with their thyroid. They could result in hyperthyroidism, hypothyroidism. But what it's usually caused from is a lack of iodine. And that's why we started putting iodine in salt. All right. And so that's why we have iodized salt. All right. Here are some iodine rich foods. So like seafood, dairy, and eggs. Those are good for goiter. Okay. So that's what a goiter is. And it usually shows up before they have thyroid problems too. So hyperthyroidism, we're going to discuss hyperthyroidism. We're going to discuss thyroid storm, because thyroid storm, I guarantee you're going to have questions on your proctor about thyroid storm. Yes.
Question.
Go
As
ahead,
far
Fun.
as with the goiter, I do. Can you hear me?
Yeah, I can hear you.
With the goiter, so
You know what? I
even
can't
though they're
hear you. You're going in and out.
you
Do you want to try to write it in the chat?
because of no
Because I think you're going in and out and I can't hear you. I think she got bumped out too. Okay, write your question in the chat and I'll come back and look at it, okay? All right, so I think she got thrown out. I think sometimes the connection isn't good when it rains, and I live close to the school. It should be fine, but sometimes it's not. All right, so all right, let's talk about hyperthyroidism. That means you have too much T3, T4, and free T4 index. Those are just the hormones. So hyperthyroidism could result from Graves' disease, which is an autoimmune disorder which often presents like a cardiac problem. Like the patient will come in with AFib and they have no idea what's going on. And this is a common story that happens. And then they're diagnosed with Graves' disease. So Graves' disease is like one of the conditions in hyperthyroidism. People can just have hyperthyroidism as well. So signs and symptoms of adults. Now with hyperthyroidism, you have to think the metabolism is really hyper, right? So it's really revved up. So you can remember the mnemonic sweating. Okay, so S stands for sweating and they will be diaphoretic. W stands for weight loss. Anytime you have unexplained weight loss, it's not a good thing, even though it's something we all dream about. It's not a good thing, okay? E is emotional lability. So that means they can be like up and down, like crazy, like you're wondering what's going on with them. Exophthalmos. Okay, so this is bug eyes. And if you look in your book, there's a really good picture showing what that looks like. And that's part of Graves' disease. A is for appetite is increased and amenorrhea. And the appetite is so big because remember, they're revved up. T is for tremor and tachycardia because they're revved up. I is for intolerance of heat. And don't mix this up because sometimes I get confused with this because I think, well, they lost a lot of weight. I would think they would hate the cold, but no, they hate the heat because their metabolism is so high. And anybody that's been in menopause knows like it feels like you're burning from the inside out and that, they cannot tolerate the heat. Insomnia. They can have insomnia, nervousness, tremors, and GI problems. So this is what's important for you to know, extremely important. Any rise in temperature greater than 1 degrees Fahrenheit may indicate an impending thyroid storm, and that's important for you to know. Now, you also need to know that older adults can present like most conditions, right, with different signs and symptoms, right? Older adults, they get confused. The first thing I think of is they have a UTI. Well, with this, they get depressed and they get apathetic, which is different than what you would expect somebody with hyperthyroidism have. But they do have weight loss, fatigue, shortness of breath, and palpitations. So it's going to be diagnosed by the presentation, ECG, and labs. Anybody that has a resting heart rate greater than 80 beats per minute while sleeping may have a thyroid problem. And they would do a thyroid scan. So the nursing implications for a thyroid scan, you have to know this. You have to figure out if there's a chance the patient may be pregnant, check what medication they're taking, and you want to see if they have had history of diagnostic tests with iodine recently, because that can trip them into hyperthyroidism. All right, so you want to keep the patient calm and provide rest, especially if they're really hyper. You might have to give them some sedatives, keep the room cool and quiet, and daily weights and eyes and nose, high calorie diet, obviously no stimulants. And they're going to need to take their anti-thyroid medication and possibly a beta blocker. That's the medication for hyperthyroidism. So you're going to collaborate with the radiologist because they're going to need scans. And also they may get something called radioactive iodine. You're going to collaborate with a dietitian because they're going to need to increase their calories, the endocrinologist because that's who handles the hormones in the body, and a pharmacist. All right. So the medical management includes a thyroidectomy and radioactive iodine. We call that I-131. Now, your book has contradicts what ATI says. So I stay away from that kind of thing on tests, but I'm just going to tell you, ATI says with radioactive iodine therapy teaching, they need to stay 1 meter away from pregnant women and also from children. Okay, that's what they say. Now, your book says like they have to be 6 feet away, they have to flush the toilet twice, but this is what ATI says. So we always go with ATI. And then signs and symptoms of radioactive iodine therapy toxicity include hematemesis, so that's throwing up blood, epistaxis, which is a bloody nose, and nausea and vomiting. So that's how you tell if they're getting toxic. Now, with thyroid surgery, they may give iodine before they go to surgery, and that's to kind of shrink the thyroid. Thyroid is highly vascular, and so you don't want the surgeon in there for a long time trying to get the thyroid out. So I like taking care of these patients too when I worked in PACU. Monitor for iodism, so metallic taste in the mouth, stomatitis, and severe nausea and vomiting, and that's because they would have got iodine before surgery. So post-operatively, the nursing implications are important for you to know. Obviously, anybody post-op, you're going to monitor their airway, but especially with thyroid because they could have swelling of their neck. So you want to make sure that they are breathing properly. One of the first things I did, obviously I put the head of the bed up so they were in semi-fowlers. You keep the head and neck in a neutral position. You don't want to let their neck extend, but I would tap them on the side of the face to see if I could elicit Shabazz text time. And I'm going to explain that in a minute. You want to make sure you're checking the dressing. Now they're going to come out and they'll have a JP drain, okay? And their dressing is going to be like on the front of their neck. but you have to assess behind them, because anytime you have somebody comes out with surgery, right? They're going to have a dressing on their front or on like a lateral part of their body. You have to roll them over and make sure they're not draining blood behind, okay? Because if somebody says to you, I feel like my neck is wet in the back, that's not a good sign after somebody's had thyroid surgery. Um, all right, so you're going to look for that. Look for hematoma formation. So my husband and I have a medical legal consulting company, and we had a case where this nurse was taking care of somebody post-thyroidectomy, and the patient developed a hematoma. And so instead of calling the provider, the nurse kept putting ice on it. Well, the patient eventually occluded their airway and died. So you have to monitor that closely, and you would have to let the provider know if somebody developed a hematoma. All right. Assess for pain and provide pain relief. So we usually give fentanyl right after the surgery. Assess the patient's voice, and this is this is important because you want to make sure there was no nerve damage done. So you're gonna discourage them from talking, but yet you have to ask them to talk at least every 2 hours to assess the nerve for laryngeal nerve damage. They're gonna have a hoarse voice for a couple of days. You're gonna expect a moderate amount of serosanguinous fluid in a JP drain usually. You're gonna monitor for hypocalcemia. The reason is um, the parathyroid is in close proximity to the thyroid. And the parathyroid glands are teeny tiny. It's very easy for the provider when they're taking out the thyroid to also inadvertently take out some parathyroid. So that's why you monitor for hypocalcemia. That's why I used to tap somebody's face when they came out and they were waking up. I would tap their face to see if they had Chvostek sign. And then I would blow up my blood pressure cuff to see if they have Trousseau sign. So you have to monitor for that, know how to monitor for that. You need the trach at the bedside and make sure your suction is working. That is so important. It's a pet peeve of mine as a nurse that you don't have emergency equipment ready to go. And then your signs and symptoms that show you that somebody's bleeding. Now, remember, I also gave you that tip about a wet neck. Okay, so anytime somebody starts bleeding, the first sign you're probably going to see is tachycardia, because tachycardia is the first sign of hypovolemic shock. So you're going to see that the patient will get restless, so they'll have restlessness. But also, if they start complaining of a tight dressing or a wet posterior neck, if the tight dressing could mean there's a hematoma in there, and you need to be afraid that they may occlude their airway. Okay, so that would be an emergency. Um, and then hypocalcemia, the signs and symptoms of that. I know you've had this since funds, but I'll just review it again real quick. So remember CATS, convulsions, Chvostek sign. They could have arrhythmias. Um, they could have tetany and tingling around the mouth, also numbness around the mouth, Trousseau sign, and stridor. So you're going to be looking for that in muscle spasms. So calcium is like, I think of calcium as a sedative. So if I don't have enough calcium, I'm going to be really spastic and have tetany and Chvostek signs. So you're going to have to know those signs and symptoms. And then the nursing implications, assess for them. Patent IV, because you may have to give calcium gluconate. And you would have a patent IV anyway for somebody in the PACU or somebody that just had this. Maintain a quiet room and keep movement of patient at a minimum. Did I tell you you need to have a trach tray? Yeah, have a trach tray at the bedside. That's because if somebody starts complaining of a tight dressing, you need to get somebody in there like a provider to help you in case they have to put that trach in. All right, thyroid storm. I bet you are going to have questions about thyroid storm on your proctor and your NCLEX. This has been around since I was in nursing school that we had to know this. Okay, now the causes of thyroid storm means like too many of the hormones are like leaking, I guess I should say, from the thyroid. That's the way I think of it. All right, so it could be caused by surgery, when it's manipulated during surgery, trauma, infection, any kind of stress, pregnancy. any kind of test with contrast medium containing iodine, like if somebody had a CAT scan with contrast, okay? Aspirin can also cause thyroid storm. So it's a rise in temperature greater than 1 degree Fahrenheit may indicate impending thyroid storm. Now, remember I told you that hyperthyroidism is being all revved up. Well, thyroid storm has those same signs and symptoms, except like it's jacked up even higher, okay? So they're going to have a high temp, a high heart rate, a high blood pressure, high respiratory rate. They'll be anxious, they'll be irritable. They could have seizures, coma, death, and chest pain. So this is like a medical emergency. These patients would go to the ICU. They need acetaminophen. They're going to need cardiac meds to bring that heart rate and blood pressure down. So like IV beta blockers, sedatives, and they go to the ICU. But make sure you can recognize this. That's very important. All right, now hypothyroidism is going to be like the opposite of hyperthyroidism. So this is underactivity of the thyroid gland, and the autoimmune type is called Hashimoto's. So risk factors include low iron, low iodine diet. That's why we started putting iodine in salt to try to prevent this. Surgery, amiodarone, which is an antidysrhythmic, or lithium therapy. Signs and symptoms, you can remember mom's so tired, which is really true. Okay, so M is for memory loss and mixed edema. O is for obesity despite being anorexic, like they don't have an appetite, but yet they cannot lose weight and they gain weight actually. M is for malar flush. Metabolism is slow and meningitis. So in in hyperthyroidism, they have amenorrhea. Okay. S is for slowness. So both mentally and physically. So they can have depression, right? They're going to have a slow heart rate, slow bowel, slow thought, and speech. S is for skin and hair dryness. O is for onset gradual. T is for tiredness, lethargy, thinning eyebrow. They have what is called a Queen Anne's eyebrow. And it's like when the last third of the eyebrow is missing. I notice this on people all the time. And you will too now that I told you that. That could be a sign of hypothyroidism. I is for intolerance to cold or irritability. R is for really low blood pressure. E is for energy levels fall. D is for depression, delayed relaxation of reflexes. Okay, so their labs are going to be low. All right, so your nursing interventions, you want to promote rest by spacing their activities because they're going to be so tired. You protect against the cold. They have a cold intolerance despite being obese. So you have to kind of get that, you wrap your head around that. Monitor their temperature, increase fluids because you want to, they're getting constipated. Orient PRN. Never use heat like electric blankets because they could burn themselves because they can't really feel it that well. And monitor for edema. Avoid fiber, laxatives, calcium, and iron because they decrease levothyroxine absorption, which is the medication they would take. So remember, you want to give that each morning before breakfast. And monitor for signs of hyperthyroidism for anybody that's on levothyroxine. All right, now your mixed edema coma is like a medical emergency. So it can be caused by stress, infection, exposure to cold, and trauma. So you would look for that. So the signs and symptoms they're going to have if they're a mixed edema coma is all these hypos, okay? Hypothermia, so they're going to have a low temperature. Hypoventilation, decreased breathing. Low blood pressure, hypotension, and hypoglycemia. And finally, they become unresponsive. So, like the most important thing for you, for somebody that's unresponsive, is to maintain a patent airway. So you're going to start the aspiration precautions. Never use electric heat. Investigate if they had an infection or a UTI, like what triggered this. Okay, so you want to do that. Daily weights and eyes and nose are important with that. And then with parathyroidism, not going to go into a lot of detail. I'll give you a few tips about parathyroidism. The reason is is it's not that common, and you only really need to know a few things. So the labs you need to look at for either hyperparathyroidism or hypoparathyroidism is phosphorus and calcium. All right. So if somebody has hyperparathyroidism, all you have to remember is high calcium, low phosphorus. If you know the signs and symptoms of high calcium, then you know the signs and symptoms of hyperparathyroidism. So I like to remember bones, stones, groans, thrones, and psychiatric overtones. Now, calcium is a sedative, okay? And it's also can make bones very strong, but also very brittle if there's too much. Okay, they can develop kidney stones if there's too much. With groans, they can develop constipation because, again, calcium is a sedative and it's going to slow down the bowel. They can have ileus and abdominal cramping. People with high calciums get what's called um, uh, nephrogenic, sorry, diabetes insipidus. You don't need to know that, but I'm just explaining that people with high calcium are going to have an increased urinary output. So that's what Thrones are. And psychiatric overtones is because calcium is such a sedative, they're very apathetic and depressed and lethargic. So that's going to be your signs and symptoms of hypoparathyroidism. So if you can just remember, hyperparathyroidism stands for high calcium, low phosphorus. And then hypoparathyroidism stands for low calcium and high phosphorus. Okay, so just remember your cats that I already talked about with that. Okay, now I made a little table here for you to compare and contrast hypo and hyperthyroidism. So just come back and spend some time with this. Um, the thing that turns me around the most is, with hyperthyroidism, they're skinny, yet they cannot stand to be in the heat. Okay, so I don't know why that turns me around so much, but you can spend some time here learning about that. Just a few things with the adrenal glands. So the adrenal glands sit on top of the kidneys, okay? And they secrete catecholamines, which is norepinephrine, the medulla, right here, and epinephrine. And then in the cortex is, and that's this right here, okay? That's where the steroids. So you have two types of steroids. You have like the mineralocorticoids, so that's your aldosterone, and the glucocorticoids, so that's cortisol. All right. Now, if somebody develops a benign tumor, it's called a pheochromocytoma, and it secretes these catecholamines, norepinephrine and epinephrine. And you know that epinephrine is what they use in cardiac arrest to try to get the heart to go because it will make your heart rate go very fast and your blood pressure to go very high. So people with pheochromocytoma present with an extremely high. They're going to be diaphoretic because their catecholamines, the epinephrine and norepinephrine, are running rampant, right? They're going to have a headache and they'll have palpitations with tachycardia and pallor. All right. They may do a 24-hour urine for VMA. They may do surgery. And after surgery, you're going to watch for an adrenal crisis. And I have a feeling that's going to be a proctor topic. I'm going to talk about that when I talk about Addison's. And don't forget to check out the Quizlet. I already made one. All right, Addison's disease. So Addison's disease is caused, and it's an adrenal disease. It's caused by two little hormones. Okay, so you can remember CAT for cortisol, aldosterone, and testosterone. So there's two little CAT. But you can also, if this helps you better, remember it. Cortisol, it's going to have too little sugar, aldosterone, too little salt, testosterone, too little sex. Okay, sugar, salt, and sex. That's what the adrenal does. Okay, so your signs and symptoms of Addison's disease, you can remember the mnemonic steroid. So the sugar and sodium is going to be low. Remember, sugar, salt, sex. All right, they're going to be tired and have muscle weakness. They're going to have a high potassium and high calcium. They'll have reproductive changes. like amenorrhea, just problems with their cycle. Low blood pressure and orthostatic hypotension. They're going to have bronze tan skin. Okay, that's classic, increased pigmentation. And then diarrhea and nausea and depression. So the lab values you're going to expect is a high potassium, decreased sodium, high white count, low glucose, and their blood and saliva cortisol is going to be decreased. So the BUN and creatinine are going to be increased. Okay. You're going to monitor for vital signs for the hypotension, for orthostatic hypotension, decreased urine output, LOC, okay, and monitor for signs and symptoms of hyperkalemia like muscle weakness, olguria, uria, and also heart problems. So they can have EKG changes with hyperkalemia. And they could also have like seizures and hyperreflexia. So fluids are going to be replaced with normal saline. Check your blood glucose, and they're going to need a high protein, high carb diet. So you're going to have to talk with a dietitian in daily weights. All right, treatment for high potassium. You can remember KIND. So Kxalate, I don't know if you've heard of that before. It can be given orally or by enema. Insulin, and you give the insulin with sugar, with dextrose, and that moves the potassium inside the cell. As long as so does bicarb, okay, and diuretics like your furosemide and thiazides. With hypoglycemia, the patient may present with hypoglycemia, especially if they have an adrenal crisis. Okay, so remember, be tired is a mnemonic you can use. So blurred vision, tachycardia, weakness, irritability and seizures, restlessness, excessive hunger, and diaphoresis. Cold and clammy, gimme candy. So if this patient is cold and clammy, you're going to get 15 grams of glucose stat. Okay. Now, the treatment for Addison's and the treatment for adrenal crisis is going to be to give them steroids. That's why you never stop steroids abruptly, because they can go into adrenal crisis, right? So the side effects of steroids, remember that they can get sick easy, they can get sad, they can retain salt and weight gain, which may increase their blood pressure. So you have to monitor for hypertension with people that are on corticosteroids. All right. And then they have to, you have to tell them to avoid crowds, take the corticosteroid with food, and increase the dose with stress. Now, stress is what causes an adrenal crisis. Like somebody has surgery, like I talked about the adrenalectomy, or they have a big surgery and they're prone to this. They could go into adrenal crisis. Anybody with affection, extreme stress in their body, anybody I told you that stops taking steroids, okay? So you're going to monitor for hypoglycemia, hyperkalemia, and hyponatremia. All right, so that's adrenal crisis. And then Cushing's is like the opposite. The body produces too much cortisol, and they'll probably need a cortisol test, and that's kind of a lot of work, but I'll talk about that in a little bit. So these signs and symptoms of Cushing's, you probably actually already heard it since you had pharmacology, because this can happen to anybody on steroids. They can get Cushing-Gold syndrome. And remember, the mnemonic stress you. So their skin gets fragile and they could have sleep disturbances. They can get psychotic too. They'll have truncal obesity with small arms. I call them like a martini olive because their belly looks so big, but their legs are so skinny. And tachycardia. They're the ones that have the round moon phase shaped. They can have ecchymosis. They can have purpura. They can have elevated blood pressure. So that's something to watch out for too. Striae on the extremities and abdomen. It's purple striae. Okay, they can have an extremely high sugar and excessive body hair, especially in women. Okay, you're going to look for a low potassium. All right, and then they're the ones that have the buffalo hump, and they could get ulcers. So the expected labs are hypernatremia, hypertension, and heart failure, increased WBC, hypokalemia, hyperglycemia, and a 24-hour urine will have high free cortisol. So they will do cortisol tests, and the patient is going to have to be woken up in the middle of the night because they have to do 2 to 3 blood draws. Okay, so you're going to tell your patient to try to avoid stress, which is nearly impossible, but you'll have to educate them. No food or exercise restrictions. Um, Make sure you know the signs and symptoms of hypokalemia. Okay, so remember, like the shallow respirations and decreased intestinal mobility and ileus. Okay, and arrhythmias and weakness. So those are the signs of Cushing's disease or syndrome. And then, wow, that went quick. Then all I have after this is diabetes next week. Is this semester going quick for you?